So it's noon. Good afternoon, everybody. Welcome to the Born Ontario webinar. My name is Anne Sprague. I'm the Scientific Manager for Born Ontario. And today we're pleased to introduce two speakers that will be talking to you about the new maternal newborn dashboard. Sandy Dunn is the Knowledge Translation Specialist here at Born Ontario and has had a lead role in developing the indicators for the dashboard, as well as working with the committee in introducing the dashboard. Sherry Kelly is an epidemiologist here at Born who has been largely responsible for developing the reporting aspect that you're going to be able to see within the Born information system related to the dashboard. And today they're going to talk to you about the maternal newborn dashboard for Ontario. They're going to introduce how it was developed. They're going to talk to you about what you'll eventually see when this system goes live in the next couple months. And we'll talk to you about how we plan to roll this out a little bit, and then how we will plan to evaluate the effectiveness of this. So thanks for joining the webinar this morning. There will be a time at the end where you will be able to type in your questions in the little chat box, and they will be able to answer your questions. So if you have questions, you can save them up to the end and type them, or you can put them in as we go along, and we'll scroll back and start at the beginning answering your questions at the end. So Sandy and Sherry, thank you for taking time to do this today. We appreciate it.
Thanks, Anne. It's Sandy. I'm going to start off the talk and give you some background information. As Anne said, I'll just go ahead to, hang on. Go ahead to move a slide. There we go. So the background information, I'm going to start off and just refocus us a little bit, take us back into the world of quality in healthcare, just for a couple of minutes to set the context in which this entire dashboard project was built from. We're going to talk about the process, as Anne said, that we went through to select the indicators that are on the inaugural dashboard, talk about the benchmarks, some of the evidence, summaries that have been developed, etc. And Sherry will then take over and talk about the data displays and what the dashboard looks like. So just moving forward then, a little bit of information about quality in healthcare. I put a definition there. I don't think this is new to anyone, but just for the purposes of us working from the same plate, the definition from the Institute of Medicine, which has been used in many contexts by many organizations over the years, is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. And so quality is a key word in Ontario and in all other provinces and around the world. In Ontario, we have new legislation that has been enacted since 2010. We know it as the Excellent Care for All Act, or Bill 46, that outlines components in some detail about what we have to do to ensure we are providing quality in our clinical setting, maternal newborn care. And it covers a number of components, and you can see them listed there. Mandate for Health Quality Ontario, work that quality committees need to be concerned with, how you develop quality improvement plans, issues related to collecting patient satisfaction information, patient experience information, patient relations processes, et cetera, et cetera. And so in Born Ontario, we, of course, have a mandate to support quality care in Ontario in relation to maternal newborn care. And so it was our purpose to move forward with this project to find ways to help facilitate quality of care. Whoops. So before we move forward into this project, it's important to figure out ways to measure quality care. It's not one concept or a construct that is measured with one thing. Quality care has been defined using a variety of different domains, and this little grid that you see on the screen just gives you an idea of 6 of the domains that we explored through this project. Accessible healthcare, quality care means having accessible care that you need available to you, care to be person-centered, equitable across all populations, effective, safe, appropriate. And there are other quality domains. We call those components quality domains. There are other domains that are used in other contexts, such as timeliness of care, that your healthcare system is responsive to needs, that healthcare is delivered efficiently. So for our purposes, these were the 6 most commonly used quality domains, and we focused on these in thinking through some of our approach to developing a resource or an innovation to assist organizations and healthcare professionals to explore these issues and identify practice gaps. So the other slide that I wanted to include, because it also just grounds this entire project and the context of this talk, is Born's mission and vision. And so Born has a vision to provide knowledge needed for the best possible beginnings for lifelong health. And the mission, to that end, the mission of Born is to facilitate and improve care. I'm going to just highlight some of the key phrases here. Number 2, to be an authoritative source of accurate, trusted, and timely information, provide scientific and technical leadership, and mobilize information and expertise. And so internally in the organization, we spend a great deal of time exploring ways that we can operationalize this mission to achieve these goals. And from our purposes in relation to the dashboard, we were particularly interested in the phrases, you can see them italicized there. How do we help organizations and healthcare providers address care gaps that can be identified? How do we help them monitor, evaluate, and plan for best possible outcomes for their clients? How do we work forward to support research and innovation? And how do we work forward to optimize care and contribute to a high-performing healthcare system? And so the idea of the dashboard concept came forward through exploration and consideration of this. And a dashboard is a concept, it's a performance measurement system that has been used in various contexts internationally throughout the world and in various areas, not just healthcare, but it's a performance measurement system that provides data on structure, process, and outcome variables and incorporates 3 key things, and they're listed there. You can see the key components, feedback, benchmark, and signal highlighted or bolded. So a dashboard would provide information to report on selected key performance indicators that were identified, would provide information to compare performance to established ideal levels, and it would provide alerts to trigger action when performance was suboptimal. And that's the concept of a dashboard. It's what it's designed to do. And as I say, they've been used for a variety of purposes in many settings. We thought this might prove to be a useful innovation to build on, and in fact there was also evidence, new evidence in fact in 2012, but building on previous evidence from Cochrane reviews that looked at the effects of audit and feedback on professional practice and healthcare outcomes. There was another Cochrane review done at about 2006, I believe, that explored through systematic review of empirical evidence about whether or not audit and feedback, which in fact is what a dashboard does, it provides information through audit and feedback through to healthcare providers and organizations about what's going on. And so this particular current Cochrane review reviewed 28 or 82 comparisons from 49 studies to see whether or not there, in fact, was evidence of effect on healthcare outcomes and practice. And it's based on the premise that healthcare providers are more likely to modify their practice when given performance feedback showing that their clinical practice is inconsistent with desirable targets. In other words, if you don't know that there is a gap, you can't move forward to address the gap. And so increasing awareness and understanding and giving some context, some explanation of what's going on is the place to start to ensure quality care is being provided. So in this Cochrane review, the authors concluded that audit and feedback as a tool was more effective if baseline performance was low, so therefore you have to be able to measure the performance, if feedback is provided more than once, and so it needs to be repetitive, and when feedback includes explicit targets and an action plan. In other words, that concept, that idea of a direction to go, where do we need to move? Is there a gap, and in what direction do we need to take things to improve care? So with that in mind, the Maternal Newborn Dashboard, or MND, as you'll see the initials here, as we refer to it lovingly now, has really been designed to provide site-specific and comparison data, or the feedback, and a visual indication of an evidence practice gap, the signal, and provide direction for practice change through a benchmark that has been set. And I'm going to just tell you a little bit about how we established all of those things, and Sherry is going to show you a visual illustration of what the dashboard would look like from the perspective of what the signal and the benchmarks are. So having decided that we felt the dashboard would be a useful tool to build into the newborn information system as a resource for healthcare providers and organizations to use to help them meet their mandate for their patient populations in relation to quality care, our dilemma was then, how do we select key performance indicators, or KPIs, to populate the dashboard? And so we came across, Herman and Palmer have developed and published a framework that gives criteria that helps to judge the appropriateness of different key performance indicators and whether or not they would be suitable to populate an innovation like the dashboard. And the three key sections, or three key components of this framework, stipulate that in order for a key performance indicator to be useful and appropriate for further exploration and to populate the dashboard, we need to identify KPIs that are clinically meaningful, feasible to measure, and actionable. In other words, clinically meaningful means that it's an important clinical issue, important component of care. It is serious. It can affect many people. It may have high costs. So there are different descriptors used, and it really depends on the area in which you work and your resources and the population you're dealing with, how you interpret what is clinically meaningful. But the point is that it needs to be an important area of care to address to be a useful KPI. And the other component is feasibility to measure it. If we can't measure it, if we can't collect the data, if the data is not good, then it really is very difficult to use this key performance indicator on a dashboard, because we need to be able to monitor and trend and track what goes on. And the third component in the Herman-Palmer framework is that the KPI you work with should be actionable. So it's really, although it's always important to address clinically meaningful issues and have feasible data, if there isn't anything that we can do about it from a systems perspective in a reasonable amount of time, it may not be the most appropriate thing to start with in the inaugural dashboard. So we use this framework to help us go through a selection process to identify key performance indicators and to shortlist them to the 6 that have been chosen to be on the inaugural dashboard. So how did we go about identifying the KPIs and shortlisting them? We developed or struck a dashboard subcommittee from our Ontario Maternal Newborn Outcomes Committee. And that subcommittee consisted of an interprofessional group of clinical experts with representation from across the province with clinical expertise in a variety of different areas: obstetrics, neonatology, pediatrics, midwifery, nursing, with research and epidemiology expertise in the group as well. And that also was combined with, we did a look through the Born Information System at data that existed, looking for high-quality data, variables with high-quality data that represented and reflected current practice issues or hot topics, or areas where there was significant variability across the province or regions of the province that weren't easily explainable. And through that process, we identified to start with, just over 24 key performance indicators of initial interest that we might move forward with. And this grid you saw before became our quality domain framework. So we used that concept of the Herman Palmer framework of clinically meaningful, feasible, and actionable to rank order our key performance indicators. And we wanted to map the selection of key performance indicators, or these data elements, against the quality domains that are listed here, because we wanted to try to design a dashboard that would be helpful for hospitals, healthcare providers, and different organizations address their quality mandate that we all work towards. So that process happened. You will see the 6 that have been selected for the dashboard in a subsequent slide coming up. I've mapped it onto this grid. I didn't put all 24 on because the font is too tiny, wouldn't have been legible, and is not no point in it at this point. But just to give you an idea, we were using evidence and informed thinking and some fairly rigorous rationale to judge the appropriateness of these indicators. So we then went through a modified Delphi process with our committee with all of this information to seek feedback about the potential indicators, to establish face validity of these indicators and prioritize the list down to a manageable number of key performance indicators. And we ended up selecting 6, which I will show you in the next slide. We developed an online survey. This group of indicators was ranked and rated according to the ones the expert clinician group felt to be the most clinically relevant and the most amenable to change, and shortlisted our list down to about a dozen, and then validated the KPIs as appropriate for use across the province by going back to the Born Information System and extracting data from the BIS to look at the historical trends in performance and quality of the data that existed. And we ended up agreeing on, or the final group of 6 KPIs that made the short list after this scrutiny are as listed here: rate of episiotomy and spontaneous vaginal birth, the rate of formula supplementation in healthy term infants whose moms intended to breastfeed, the rate of repeat cesarean section in low-risk women not in labor done prior to 39 weeks, the proportion of laboring women delivered at term who had GBS screening at 35 to 37 weeks, the proportion of women induced with an indication of post-date who were actually less than 41 weeks at delivery, and the rate of unsatisfactory samples for newborn screening. So although we don't have a key performance indicator in every single area of practice, antenatal, intrapartum, postpartum, newborn, we do have a good range. We also, that was another sort of guiding principle that we worked with. We wanted to try to have a range of clinical practice areas that were covered by these indicators, not just have everything lumped and addressed by care in one area, for example, during the intrapartum period. So although, you know, oftentimes we hear people say, oh, well, why didn't you include? Why didn't you include? Why didn't you include? And there's always another list of indicators, and there is. I mean, the idea of this dashboard, this inaugural dashboard, was to use some extensive development time and expertise to come up with a place to start, to test out the system, develop the resources, and to then build from that so that in the future we will be able to add clinically meaningful and what are felt to be, as time goes on, very appropriate indicators that are meaningful to track across the province that need to be addressed. But to begin with, we have come up with this group of 6 to start with. And so there are the 6 plotted on our quality domains grid that just gives you, you can see they really fall into the effective, safe, and appropriate domains. Not to say the other domains aren't critically important either, but as we say, the information in the Born Information System is more conducive to some of the domains than others. So this gives you an idea of how they map and the fit with quality domains to be able to move forward and say, well, you know, one way for us to measure effectiveness of the care we provide is to look at these three domains of Group B strep screening, formula supplementation, and episiotomy and spontaneous vaginal birth, to look at our rates and to be able to speak to a mandate of providing effective maternal newborn care with these three domains and these quality indicators as a proxy measure for quality care. So the benchmarks was another phase once we actually got through the process of identifying the key performance indicators. As you remember, as you recall, as I showed you at the beginning, dashboards, one of the key components of a dashboard is to be able to identify a practice gap and to be able to provide information and direction for improvements. And so that is where the concept of identifying benchmark rates to provide guidance for healthcare providers and organizations, the direction to move, the roadmap, if you will, the direction you need to move if, in fact, there is an evidence practice gap identified. So we use various forms of evidence to establish performance benchmarks. I mean, ideally, we wanted to be able to set benchmarks based on the empirical evidence in the literature, and after considerable scrutiny and through development of evidence summaries that were developed for each of these quality indicators, we were not able to actually find evidence in the peer-reviewed literature. So we also used, completed a review of current clinical practice across Ontario and used clinical expertise of our committees and expert opinion and considerable debate about what would be a reasonable place to start. So I won't show you these now. Sherry will have a display of the benchmarks as they're profiled in the dashboard in her screen. So there is a benchmark. There are 3 lights that are set for each indicator and a benchmark rate that gives a target rate. I mean, if you have a green light, you're achieving the target rate. If you have a yellow light, you're just off target slightly, so it's a little warning to say you might want to look at this or monitor it over time to see where you go. And there's a red light that is an alert signal for you to say we really need to explore what's going on here. And so this is a picture of one of the evidence, KTA, Knowledge to Action Evidence Summary that was developed. This is the one for the elective repeat cesarean section key performance indicator. But as I say, there's an evidence summary that's been developed for each key performance indicator in collaboration with the Ottawa Hospital Research Institute Knowledge to Action Research Center. And the information will be posted on the Bourne's website and will be available through your Bourne regional coordinators and Bourne Central as we move forward. But just to know, there was an effort made to do a scoping review of the evidence related to each one of these indicators for 2 reasons. Number one, to try to bring the evidence together in one place to save time and facilitate review and access to information to support these indicators, to say they were clinically meaningful. It is important to look at these, and these indicators all reflect practices that have implications for patient outcome and subsequently quality care. So that was done. And just moving forward. And so now I'm going to pause because that's an overview for now, just of the development process that we went through, and I'm going to pass the mic, if you will, over to Sherry virtually, who's speaking to us from British Columbia, actually, and she's going to walk you through the next few slides, which show you a display of what the dashboard will look like. Sherry, do you want me to do the slides when you
Please,
just tell me when?
Great. Thanks, Sandy.
Okay.
Thanks so much. So as Sandy said, my name is Sherry Kelly, and I'm the epidemiologist with Bourne, and I've been involved with the development of the dashboard in the Bourne Information System. And hopefully the users on the line have either accessed the Bourne Information System already or are familiar with it. And this will just be a look back at how to access the Bourne Information System. So we've put up on the line the URL. It's https for the secure and my.bourneontario.ca. And once you are going to be accessing the Bourne Information System, of course, you'll need a user account. So this is managed by your local administrator, and so once you have your login credentials, you'll be able to log into the site. Next slide, please, Sandy.
Oh, hang on, sorry. Got it. Okay.
Great, thank you. So once you're in the Born Information System, it looks like this. And you'll have at the top a few menu items. And what I wanted to point your attention to is right next to the announcement section at the bottom, you're going to see the landing page for the dashboard once it goes live. And it'll look something like this. Next page, please. Okay, great. And so the maternal newborn dashboard landing page will look like this. You'll have the list of the 6 key performance indicators that Sandy has already listed, the rate of unsatisfactory samples, the rate of episiotomy, the rate of repeat C-section, and so forth on the left. The next column will give you your rate percentage. So for an example, the rate of unsatisfactory samples for your site would be 5.0. And this would give you the status color, so the red light, that you would know that for this particular indicator for this period, your status is red. So this is something that you would want to pay special attention to. So with all of our tables in the Born Information System, we also quote a data source. So this is, of course, from Born, Ontario, data collected through the Born Information System. And there are notes just to point you to special details. Here it's the rate and status are based on 3 previous months of data for which data submission has been acknowledged for all 3 months. So that's of particular interest. And we have based these rates on 3 months' worth of data. So if you can see underneath the title, Maternal Newborn Dashboard's landing page, you can see this is just an example for your hospital, your site, from April 1st of this year to the end of June, so that would be 3 consecutive months, if you've acknowledged those months of data. And we are paying special attention to data acknowledgement. Those of you who have been involved in the data entry process will know that there's a data quality management process by which you need to validate your data, make sure there's not a great amount of missing data, and then you can do your reconciliation and do your month-end acknowledgement. So once you've acknowledged 3 months of data consecutively, so if we were to, as an example, have logged into this database in July, the 3 previous months, April, May, and June, will have had to be acknowledged for these rate values to appear in the dashboard. If they don't appear, you won't see the value, and the status will be grayed out. The next note is just to remind you to please complete month-end acknowledgement for the key performance indicators with missing values for rate and gray-colored statuses, if applicable. Next slide, please, Sandy. Okay. So here is where we wanted to just show you what would happen when you want to go to further information on the maternal newborn dashboard. So this is within the reporting section. So up on the top right, you can see the word reporting in blue, and this will then, you will then be navigated to the reporting section. You can see there are 4 tabs. The first tab is labeled dashboards, and right now we have a notice message saying that the maternal newborn dashboard is going to be coming very shortly, so please stay tuned. But what will appear, next slide please, is the maternal newborn dashboard homepage. So this is what you saw on the landing page plus more information. So you'll have the same list of your 6 key performance indicators with the rate percentages, the status circles, but then we will also list the benchmarks that have been decided upon through the process that Sandy went through. And so for an example, the rate of unsatisfactory samples for newborn screening, the first KPI I have listed here, you can see that for your site, your status may be red, and you know that the red alert status is for rate values greater than 3. So you know that you have a rate of 5 that's quite high. If you wanted to then move towards the target of less than 2.0, you'd have to work towards that. You can see that these are just mock-ups. If you're talking about, for instance, the proportion of women who delivered at term with group B strep screening, you can see that your status is green, and that's any status that's greater than or equal to 90%. So you can see the benchmarks next to your statuses, so that gives you more information about where you fall. And the next section is the comparator data. And what we mean by that is the comparator groups, your peers. So if you're a level 2 site, the other same level of care hospitals, all the other 2s, we will have taken a mean or an average of all those hospitals who have acknowledged their data for the last 3 months to give you this value for the first KPI of 4, and so that you know if your rate is 5, your peers in the other same level of care hospitals have a rate of 4, so you know where you fall in compared to your peer groups. The next comparator group is other similar birth volume hospitals. So we have groupings of birth volume hospitals, for an example, between 1 and 500 births a year, 501 to 1,000 births a year, and so forth. So you will fall into your particular group by birth volume, and you know that your birth volume, similar birth volume hospitals for this indicator had a rate of 4.3. And the last comparator, of course, is for all the hospitals in Ontario, again, who have acknowledged their data for the last 3 months listed in this reporting period. And again, you will be included in this category because we include all hospitals in Ontario, whereas for the other 2 comparator groups, it's the other hospitals that we're comparing you to. You're not included in those 2 groups, your data from your hospital. So hopefully that's clear. This is a lot of information, of course. When you go to the reporting homepage, you can see all your 6 KPIs, the rates, status, benchmarks, and comparator data in one glance. Of course, there are always the data source noted and the notes below. Now, we wanted to give you even more information so you can drill down to more detailed information. So if you were to click on the rate of repeat cesarean section for low-risk women prior to 39 weeks gestation, as an example, next slide, please, Sandy. It would lead you to a dashboard report. We've created a maternal newborn dashboard report. And, of course, this slide is very full, but I wanted to show you the report in one glance. And it would give you the same information that you saw on the home page. However, we would be breaking it down by fiscal year, quarter, as well as month. So you can see your information for April, May, and June for each month in that reporting period that would be selected for you if you logged in July. For this report, you can also go and specify the reporting period for which you're interested. For an example, once you get a fiscal year worth of data in the system, you can choose to show the data for that entire fiscal year. This is just a mock-up report, but I just wanted to show you that you would have within your hospital section, you would have the first column, which is the denominator, the number of women who had a repeat cesarean delivery at term. Next to it would be the actual value that we're monitoring, which is the number of women who had a cesarean delivery prior to 39 weeks gestation. So that's your numerator. And then the next column is the percentage calculation, which is the numerator, the women who had C-section prior to 39 weeks, over all the women who had repeat cesarean sections greater than equal to 37 weeks or at term, to give you your percentage rate. There's also missing data. If there's missing data for a particular detail or item within that is involved in this indicator, we would list the missing data there. So those are the number of records that had missing data and the percentage for the missingness. Next to your hospital data, you would have the data for the 3 comparator groups: other same level of care hospital, other similar birth volume hospital, and for the province of Ontario. These are, of course, mean values, and we would be showing you the percentage for those groups, as well as a 95% confidence interval, which would give you a range as we are calculating a mean, and the range would indicate to you how much confidence you can have in this value. If the range is wide, of course, you can have less confidence that the number could fall anywhere in that range. If the range is tight, of course, you can have more confidence to know that that's a more reflective value. The one thing to note, if we look down at the bottom of this slide, I know it's small, but for April, for the comparator groups, we list the number of hospitals that acknowledged their data for that particular month out of the total number of hospitals that could have acknowledged. So for an example, in the month of April, we see that for the other same level of care hospitals in your group, let's say level 2 or level 3 or level 1, what have you, and these are just example numbers, there were 12 hospitals who acknowledged their data for the month of April out of a total of 15 hospitals in the level 2 care group that could have acknowledged their data, excluding your data. And we can see if you move across to Ontario, as an example here, there were 85 hospitals out of a total of 105, including your hospital, that acknowledged their data that were used to calculate this mean for the comparator group for the province. Hopefully that's clear. I realize it's a lot of detail in this report, but we wanted to give you the option to drill down to the month, the quarter, the fiscal year level, also to see your hospital's data next to those of the comparator groups, to give you some indication of the confidence interval, and also to show you how many hospitals acknowledged in those comparator groups for a particular month, so you have an idea. We have a restriction or a cutoff whereby we need to have at least 3 hospitals who acknowledged in that particular month or even the quarter when it rolls up to status before we display the information. We wouldn't want to use it as a comparator if there were 1 or 2 hospitals, as that might not be as reflective as of the average of the mean of the larger group. At the top there is a legend, and presumably it'll be underneath the table, but we just wanted to show you, these are examples of what a benchmark rate legend would look like. So next slide, please, Sandy. Thanks. So again, I just wanted to make a few notes about the data that you will see in the home page, the landing page, and the report. So you get progressively more and more information as you drill into this dashboard. So for your hospital data, again, I sound like a broken record, but it's always about data acknowledgement. We want to ensure that, of course, you are using the most complete and accurate information possible for the data with which we're going to be displaying in the dashboard, such that you can have the most confidence that this is reflective of what's been entered for your hospital site. It's been validated and acknowledged by your team, and they say, this is complete and accurate data, the most data we have available to us at the highest quality, and therefore this is what we were using for the last 3 months to show you the status of your particular KPI. So that's very important. If you don't acknowledge your data, you're not able to acknowledge your data, the status will be grayed out until which point you're able to enter your data for the last previous 3 months. So if we were in the month of September, it would be the month of August, July, and June that you would need to acknowledge your data for within the month of September in order for your dashboard circle to light up and the rate to show. Of course, the benchmarks are shown in not the home page, but in the home page, not the landing page. And Sandy has gone through, of course, how those benchmarks were established and reviewed. Of course, these benchmarks are what we're using at Go Live for the dashboard, and going forward, it would be something that would be reviewed at various phases throughout the life of the dashboard. As more and more sites are meeting their target, if the dashboards need to be adjusted, that would be something that would be revisited, of course, and on a consultation basis, and notice would be provided. And I also showed you for your hospital data, if there is any missing data, we show the number of missing records for that particular KPI. And we're giving you, not when you first land on the Born Information System, but when you go to the reporting homepage, you'll see the comparator data, and also just to keep in mind that the comparator data has also, your peers will also have to have acknowledged their data for that data to show up, and we also report confidence intervals after we calculate the mean. So we hope to provide you with the most amount of information we can, the highest quality of information that's been collected in the Born Information System, so that you can be best informed about your performance compared to the performance of the hospitals in your peer groups, to make the best decisions about where to go with this information for these key performance indicators. Next slide, please, Sandy. Okay, thank you. And this is just a slide about the second phase of the dashboard report. Underneath that original table that I showed you 2 slides ago, we're going to be adding a graph that is a trending graph. And so the values that were shown for you for a particular fiscal year, quarter, even into the next fiscal year and the next quarter, if you had a status of yellow for the 2011-12 fiscal year, it would be plotted on this graph for the percentage of women who had a repeat C-section less than 39 weeks. And then throughout the quarters, the values would be plotted, as well as a bar next to the graph that shows you what the target warning and alert values are, and as well notes underneath the graph. And that's all we wanted to show you, so just to let you know that that's coming soon. It's something we want to develop and provide to you, more information in the report. And, of course, just to mention, once you do have your user account for the Born information, many of you already will have this account. You may have access to the reporting system, but if not, in order to access this dashboard report once it's available, you'll need access to the reporting role. So now I'm going to turn it back to Sandy Dunn so she can go through the next steps for the maternal newborn dashboard. Thanks,
Sherry. So there's just 2 slides left. We'll wrap up. We wanted to give you a sense of what's coming. Our next steps, of course, is communication rollout. We have disseminated a Born Bulletin in July to a large readership through the province, just giving people a heads up the dashboard was coming with a little bit of descriptive information. This Born Ontario webinar today is additional information drilling down into more detail about background and what it looks like, how to use it. And this webinar will be available on the Born website, so for anyone who wants to review it later, or for your colleagues who weren't able to listen in, the information will be there. We're developing targeted messaging and working in partnership with PCMCH to get the message through to hospital CEOs and hospital chiefs and directors about this in a tool and how it can be used and the implications for your hospital. Born training webinars will be made available as well. They will be offered in this type of format, but with more detail and examples shown, and potentially with some live data that can illustrate how the dashboard display works. So stay tuned for that offering. They will be announced, and you'll be able to log on, or let your colleagues know that they can log on. And Born support, of course, will be ongoing. We have our wonderful regional coordinator team across the province who will be and continue to be your key contacts through the rollout of all of the BIS, Born Information System, the report capability of other types of key indicator reports, as well as the dashboard. The Born Science team here as well at Born Central. We have clinical experts that are a part of our team that can help champion the message and working with this using the maternal newborn dashboard, helping with the interpretation of data and how to move forward with knowledge translation support. And our plan in the future, as Sherry mentioned as well, new dashboards will be or are in the works for future development for other program areas, as well as this sense that once we have this dashboard rolled out, that there will be a cycle and we can add and retire key indicators as need be in the future. And so the final slide is really just to say our key messages to you today are to let you know that the maternal newborn dashboard, we certainly feel, is an innovative, evidence-informed, and by that we mean an integration of experience, judgment, and expertise based on the best available evidence from systematic research as well. Been designed as an audit and feedback tool to help healthcare providers and organizations monitor performance within their own organizations, identify evidence practice gaps, share best practices, facilitate practice change to enhance quality care. So that's the ultimate goal of this product. The inaugural maternal newborn dashboard is primarily about hospital performance. That was the context in which these key performance indicators were identified. However, there's capability for everyone to use this tool to enhance quality. And for it to be effective, it's important for all hospital care providers, midwives, nurses, physicians, administrators, to understand, to know about this tool, understand how it works, and to use it to explore practice in their own setting. And so, for example, although it is not designed and does not yet display information in relation to midwifery practice groups, it's more specific to the hospital because that was the place we started. Midwives are hospital users as well in the role they play to provide service to pregnant women, and they will be able to access the dashboard as hospital users in the hospitals they have privileges in. The third point to make is the maternal newborn dashboard is the first example of a number of dashboards that we hope to design and incorporate into the biz in the future. And as Sherry has said, and I can't help but emphasize again, timely, valid, and reliable data is key. Without it, the system does not work, and it does not provide the resource that you need to work within your organizations to optimize care for your client population. So getting complete and validated data into the system as close to real time as possible is what drives the dashboard displays, is what generates the comparison data, and it's what will increase the reliability of the information that's provided to you that you can then move forward to work with. And so on that note, I'll just say thanks from Sherry and I, and open up the rest of our time for questions that you may have. If you want to just type your questions into the little chat box at the upper left corner of your screen, we'll scroll through those and do our best to answer what we can. I'll just scroll up to the top here and see. First question, is there a way we can get a copy of these slides? And I believe I just said they'll be posted on the Bourne website. So yes, you certainly can access the slides. Sherry, maybe you can handle this one. As more hospitals add data, are the previous 3 months refreshed?
Yes, good question. Thank you. And like Sandy said, this is a real-time display of data other than the fact it's for the last 3 months. But the actual reporting system is refreshed daily. So at 3 a.m. it's refreshed. So if, let's say, your hospital site acknowledges that very last month of data in June, so that you have April, May, and June worth of data, you will then see your rate appear and your status filled in, either red, yellow, or hopefully green, and it will be refreshed on a daily basis. As well for the comparator group, the same applies. If a comparator group adds data, the next day you will see that data be appearing within the mean calculation for that particular comparator group. So yes, the reporting system is refreshed on a daily basis. Any more questions, Sandy?
Will you be able to provide the full references for the sources you cited? That would be helpful if possible. And yes, absolutely, we can do that. How do we do that?
So you can either email Sandy, or actually what we could do is put out some references at the end of the slide deck.
Okay.
That's what we'll do. We'll repost the slides with the references at the end of the slide deck, and we should be able to do that by tomorrow. Won't be a problem. So it's going up. Sorry, questions are coming in, and we have to keep moving up to catch them. Just a compliment from somebody that it looked good, so that's nice. Who can get access to the maternal newborn dashboard website? Can public health also get access to this information? For those of you who are on the call from public health, you'll know that we are working with you to develop reporting that meets your needs. Right now, the dashboard is meant for the hospitals that contribute data to the system. So those would be the only people who can see their performance. And public health is getting different access for reporting. So we can talk more about what would meet the needs of public health to see that. But mostly this is about performance in the hospitals on those particular things, whereas public health generally has needs for data about things that are important to public health. So the breastfeeding one was a perfect example, and we would find another way to get you that information. So stay tuned for public health. The next question is, when is it anticipated that data will be available for public health units to analyze? And again, this session here is mostly about the dashboard. We are working with our public health partners to get you access to the Born Information System, so stay tuned for more information about that. There's a question about what is the target rate for cesarean section, and the target rate to be in the green. Remember, this is not just any cesarean sections. This is only for a very specific group. This is the repeat cesarean sections in low-risk women, so those women that don't have medical or obstetrical complications that would necessitate the possibility of a cesarean section, and these are the ones done prior to 39 weeks gestation. And the target rate is less than 10%. Now, this question I see is coming from somebody in the Champlain-Lynn region, where when that project started, there was a different rate. It was originally set at under 30%. However, recognizing that this is a practice that shouldn't happen, we have adjusted now the benchmark down lower to probably where it should be, and that process will take time to change. There was a question, this tool is great, and do we have a copyright to use the tool in another area? I'm not sure I get the gist of that question. The Born Information System is the only place where this dashboard, of course, anybody can develop a dashboard for their clinical practice looking at their data, and you should feel free to use that type of quality performance process to look at your data. The actual tool itself in the Born Information System will only run on the Born Information System, but the concept of using a dashboard is perfectly fine to use anywhere. Oh, sorry. Sorry, scrolling down through the questions. This one will be for you, Sherry. Will users be able to save and export their results?
Right, another good question. So the last part that I showed you, the maternal newborn dashboard report, like all other reports in the Born Information System, you can export it. You can export it in different formats. This would probably work best if you exported it to Excel. You could also export it to a PDF or to Word. You can then save it to your personal network drive or computer. We would recommend that you saved it to a secure network drive, of course, as this is information from your particular hospital group, and keep it securely saved. As for the landing and the home pages, we're working with the developers to see how these will function. We can check about whether or not you can actually export that image. If not, of course, as a quick solution, you can take a screenshot and paste it into a particular report to your stakeholders or otherwise. But, of course, the dashboard reports themselves, yes, you can export them to Excel. And once in Excel, you can use that data for further analysis and manipulation to meet your purposes. Back to you, Anne.
Thanks, Sherry. There's another question about when we expect the dashboard will be available. We haven't set a firm go-live date yet because we're still working on reporting and finishing up everything. We expect it will be this fall. I don't think we have a very firm deadline yet, but we're, as Sandy mentioned, preparing an extensive communication plan to go along with that, so this will all be communicated to everybody. And then I think that's the end of the questions. We'll just wait a second, but if there's no other questions, I would just like to thank Sherry and Sandy for the presentation. I think this tool will be, as Sandy mentioned, a tremendous resource for hospitals within the maternal, newborn, maternal child area. I think we're going to be well ahead of many other groups in being able to report to your management. You're going to be able to report to your management groups and your board about the quality of care that you're providing in your maternal newborn setting. So I think that's a really good way to go ahead and certainly meets the mandate of the Excellent Care for All legislation and the requirements that hospitals have under the legislation to report on quality. So if there's no other questions, again, thank you to Sandy and Sherry their expertise, and stay tuned because we will certainly be in touch as we go forward with this. Just to let you know as well, just to finalize, we have submitted 2 publications related to this because we're all about science. In addition to quality, we're all about science. So we have submitted 2 publications that are in revision now, and hopefully we'll be able to tell you soon about that. And we've also submitted a grant proposal to go ahead and evaluate this process, find out how this new electronic audit and feedback innovation will make a difference for practice change in Ontario. So stay tuned for those results. So thank you, everybody, and we'll see you for the next Born webinar, probably in September or October, but we'll get back to you with a firm date for that. So thank you very much.